And good evening, everybody. I would like to welcome everybody to this webinar on the topic of mental health and telehealth. And I'm accompanied today by a beautiful panel, which I'll introduce in a second. Topics today will be looking into successful cases and implementation of telehealth within the realm of mental health, including the primary and secondary services and acute services, and obviously within the GPs as well. How about we'll start by introducing us one by one, and by no specific order. I'll just go by my screen. Is that okay with you guys? David Goddard. Good evening.
Thanks, Yariv, and kia ora koutou. So my name is David Goddard. I'm a psychiatrist and clinical lead for the mental health and addiction lines at Whakarangaro, the National Telehealth Service.
Welcome, David. Lindy, do you want to go next?
Thank you. Kia ora koutou. My name is Lindy Matthews. I'm a general psychiatrist who, one of my roles is currently as a clinical lead for projects with Whakarangaro Aotearoa National Telehealth Service.
Cool. Thank you for joining us, Lindy. Ruth, you want to say hi?
Kia ora everyone. I'm Dr. Ruth Large. I'm an emergency physician and the chair of the New Zealand Telehealth Leadership Group.
Welcome, Ruth. And Janine.
Kia ora koutou. I'm Janine Bycroft. I'm a GP based in Mount Wellington in Auckland, and I'm the Executive Director for Health Navigator Charitable Trust.
Oh, hello, Janine. And last and not least, Siali.
Hello, everybody. My name is Siali Foliaki. I'm the youngest of the three psychiatrists present on the panel tonight. And can I say that I've looked upwards at my senior colleagues to Lindy and Dave for a long, long time in admiration. It's nice to be on the panel together with them. And I am the clinical lead of the acute end of our service. I am in charge of the earlier mental health response team, which triages urgent calls for secondary services and ensures those people calling get the service that they need.
Awesome. So thank you all for joining us in this time of the evening. Lindy, how about you'll help us to start today? Obviously, we have a heavy representation from Whakarangaro today. Can you start us off by telling us a bit about the service and what is it that you do?
Yeah, happy to. It'll be a real thumbnail. So basically, the National Telehealth Service started off in October 2015. It went live, but it started live as a GP answering service for after-hours calls. And four big PHOs got together to form Home Care Medical. I think that's correct. And they pitched for a government tender for a 10-year contract to provide a single platform to bring together several existing helplines across health in New Zealand. And those were the depression line, quit line, the health line, gambling helpline, and the alcohol and drug line. And I got in at the beginning. I was the single lead psychiatrist with a physician who was the clinical director at that point. It was a massive learning curve. And over a 14-week period, this single IT system was built. People were recruited, and those lines with their original names went live, I think it was the 5th of October, 2015. Since that time, the consolidation that was allowed by having people all under one roof, learning capacity, the capacity to upscale. We're now sitting, I've just been told, at over 30 lines that this service is servicing. And what I can say is that even in the last 12 months, our staff numbers have increased 3 times, I believe. I think we're now up to 1,200 staff, having been at about 400 about 15 months ago. And that is because the lines that we've now got running, we've differentiated some lines. We've got some different contracts. We've responded with putting up lines where they've been needed, like for the Canterbury earthquakes. So at the moment we're running amongst these 30 is we have a mental health and addiction service, which services a whole range of lines, some of which you'll hear about. We've got 1737 Need to Talk, and that was a decision made reasonably early on because the depression line we felt sounded not only a little boring, but kind of required people to think about whether or not they were depressed before they picked it up and called. So I'm not going to witter on anymore. Suffice to say that has been the growth in the service. In 2016, David and Ciali joined the service because it had already grown to a very significant extent. And we sit alongside Healthline, the COVID-19 line, and we do a lot of cross-pollination. And it's fantastic to welcome Ruth as our new boss. And that's been a fantastic achievement, I think, getting her in there, because we are actually quite a small team of doctors sitting in these lead roles, and we all work together across all of those lines as needed. So I'm going to just swiftly pass the baton over to David or back to you.
Before I let you do that, can I ask you, Lindy, about a quick question from technology? So you're saying lines. So is the service 100% based on telephones as part of telehealth, or do you provide other technologies as well to engage?
Look, the telephone lines, but those also use SMS, is increasingly, and on some lines, in fact, a more popular side of the business. My colleagues will interrupt me where my tech expertise runs out. I'm the ultimate end user. That's my usefulness. We also use email, web chat. So now our capacity, we went from telephone answering to include these other modalities, if you like.
That really happened with the evolution of 1737 as the one go-to channel for mental health. And one of the really great outcomes of particularly the SMS text capability was that we saw a huge upsurge in access from young people who hitherto had not been high users of the telephone-based services.
Okay, that's interesting. Hey, David, while we have you, it's my understanding that you do a lot in the field of the primary mental health services. Within your organization.
So, I've really spent the last 20 plus years of my career kind of leading, developing primary mental health programs. So I guess the extension into the telehealth service was a relatively logical one for me, because as opposed to most primary care, which is via a general practice, this is actually direct population primary care. The mental health addiction lines, 1737, drug alcohol helpline, gambling line, depression line, and so on, are all provided free 24/7 direct to the community. The really astonishing thing about bringing all these lines together is that, as a health sector, we kind of treat health in silos. So we had all these siloed standalone helplines, whereas the reality is few people have a pure gambling issue or pure depression. The norm we know is to have issues across mental, physical health and addictions for many people. So the bringing together and kind of taking an approach where we have areas of expertise. So we have dedicated gambling, dedicated drug alcohol practitioners, but also a general skill base so that anyone on any of those lines can respond capably to any presenting issue. And the other great thing is the linkage over to Healthline as well, because many people who access mental health lines have physical health problems and vice versa. And so there's capacity to kind of support services across the mind-body divide and also transfer people. So someone rings Healthline, but actually their chest discomfort is a panic attack. And so they can be transferred over to a mental health clinician who can talk them through the steps to take to actually manage panic.
Yeah. David, you mentioned the word access. So we are obviously in a night about telehealth. We know that accessibilities can be improved by telehealth with phone or chats or whatever. Do you think there's what do you think the advantages in specifically to primary services? If you think about this group of say people who deal with gambling and addictions, do you think they'll use more if we have more services alike?
I think there are a number of responses to that. The first is that in terms of primary care, I tend to talk about particularly 1737, encourage GPs to think of 1737 as like a virtual 24-hour available part of their service. And so for people they see who are struggling with distress, to really have it as a standard part of practice is to give them the 1737 number and encourage them to use it if they're distressed or feeling at risk. But the second thing is that through all the direct-to-public promotion, we know that for people with mental health and addictions, reaching out for help is difficult because of all the barriers we know about. And I mean, in fact, for far too many people in this country, it's easier to die than to reach out for help. So I think one of the things that these lines provide is anonymity and a safe way of reaching out to people who are distressed but who feel too much shame or stigma to be able to reach out to face-to-face helping services. And so part of the value of them is not only by providing a safe, anonymous way of reaching out for help, but also being able to really give people an experience where actually they find that it's okay, that the world doesn't end by reaching out for help, and that actually part of the role we can take is to encourage people to then seek local face-to-face help, including most often via their GP, and if necessary, pathway them to other forms of local help.
Right. Thank you for that, David. So we're mentioning Siale. Maybe the next question I'll direct to you. So obviously we have the 1737, and we have the drugs, and then we have the acute presentations, and someone needs to kind of help them to hand over to secondary services in the DHBs. Can you tell us a bit about that?
Absolutely. So if you think about even Healthline, for example, and David mentioned that Healthline is a virtual primary care setting in some respects. And if you think about, the evidence is somewhere between 30, even up to some research says up to 60% of presentations into primary care have a significant mental health component. And if you think about 1737, if you think about the gambling line, depression line, all these lines that feed in, these are distressed New Zealanders. And we have to have a system whereby if during a conversation on any one of these lines, one of our staff recognizes that there is significant risk to the individual calling, then we need a mechanism of triaging that risk and responding appropriately to that risk. So the earlier mental health response team, which is made up of approximately 34 staff now, these are experienced secondary mental health clinicians, really, but they're operating in a system now where we've got all these New Zealanders that are stressed feeding into our lines, and if the level of risk is sufficient, we need to be able to triage that risk and respond appropriately. We need to be able to do that internally in respect to those other lines, but essentially the main role that we provide is for secondary care. And secondary care now, 59% of New Zealanders and the DHBs that they belong to are now catered for by the earlier mental health response line. And what that means is, if you called traditionally, if you were after hours 4:30 until 8:30 in the morning, when the daytime mental health services are no longer, when it gets handed over to after hours, if you call the hospital, whether it's in Wanganui, Northland, Counties Manukau, and other DHBs that we provide services for, you get put through to the MHR nursing staff. They use the UK triage scale, which triages basically on acuity and risk, and it's a measure of response time. So, for example, it goes from category A to G. If you're an A, you need an immediate response. Sirens, ambulances, and police cars heading out the door to hopefully do something that's going to save a life. And it goes right down to G. G is, it's not an emergency. It's something to be handled over the next month, and you get a referral into the system. But you can't provide a virtual care system without having sharp end of the stick, where if people are at risk, then they need to be triaged, and an appropriate response to that triage needs to take place. And that's what I'm responsible for.
Right. Thank you for that. There's an interesting question here from Frank. I might just rephrase some of it, and I'm sorry, Frank, if I hope I'm getting it. But there's an opportunity here, really thinking that you guys are so accessible through telephone and chats. Is there maybe a better potential here to start and integrating systems? I mean, if someone sits in a clinic seeing his nephrologist and has depression as a comorbidity, do we see ourselves, with the vision of one health system and maybe some more streamlined resources? Allow ourselves to fantasize here. I'm opening the question for the whole floor here. Allow ourselves to fantasize about, can we somehow use this beautiful platform of yours to better integrate medicine? Give yourself a second. And Janine, maybe you want to, I don't know, Janine, see if you can imagine, say, sitting in your room, someone comes with, multiple comorbidities. Yes. Lindy, yeah, sure.
Maybe just pick off here, I guess. What Ciali's described with the earlier mental health response team, which is a team that I know well, is that was a deliberate recruitment of experienced mental health staff to deliver that level of capacity, if you like. Yeah. Most of our staff we have are counsellors. Many of them are registered health practitioners, but not all of them. And particularly with COVID, for instance, there has been some incredible innovation in recruiting people to answer the COVID-19 line. And that has been medically led. It was led by Kristen Good, who's still got an attachment to our organisation, with very close scripting, with being able to capacity to give information out. Us psychiatrists actually help to train them to manage difficult calls and to recognise distress. We had escalation pathways. But I think we need, while we're very proud of the services that we run, we need to be clear about the scale and the scope of practice of the people answering the lines. So for my pick, and other people may have a different view, we are a primary community first response service by and large within mental health. So we're a service that can be more available 24/7 to people's patients after hours and across hours. We've got some we'd love to see, and I can talk a little bit more about this later, with a complex caller team, which we set up this year, to manage those people who clearly have become familiar to us, who will be familiar to their own doctors and teams working all over the country. So we'd be keen to have some shared planning and some shared care. But in terms of, the simple answer to your question is, of course, yes, we want one health system. Of course we do, yes. Yeah. But people need to be very clear, and this role and working in telehealth is certainly something that I have really learned about, is at all times we need to be mindful of who is doing what and who is trained for what, and have they got the right support, the right training, the right background. And that takes a great deal of good communication once you go out beyond the service, I think.
Yeah. Just for me to get my head around your service, I don't know, Ruth, if you want to answer, or otherwise. By the way, Ruth, we did present you, didn't we? Yeah. What an average day? What sort of numbers are you looking in terms of primary and acute services or requests? Does anyone know roughly?
Thousands.
1,000 per day.
Thousands, yeah.
If you combine all the lines, it is literally thousands. And over the period of a year, I think that we provide services to 700 and something thousand New Zealanders across the various lines. That there was also a huge, we're very much there as a kind of a bit of a sponge to soak up need through events that create demand. So, for example, after the Christchurch earthquakes, after the Christchurch terror attacks, with COVID, various parts of the service have all had huge increases in demand. And part of the great strength of the organisation is the capability of its management team to really upscale services quite rapidly to respond to that demand.
Mm-hmm. So we mentioned COVID. I've read from colleagues in the States that their helpline saw an increase in the last year of 1,200% in reaching out to your equivalent in the States. What were the changes or trends that you've seen during or after COVID? Lindy, do you want to? I know you have something to say about some changes you guys made.
Well, I think the thing with COVID was, look, I know everyone will be waiting this for sort of, the brag factor or the bullshit factor, but that's really not what it's like. For me, I think that working as a medical practitioner in an environment like this is really novel and has been very exciting because you're working with IT people, you're working with business people, communications people, the quality of which I've never worked with previously. But so it is set up as an organisation which has had a really nice kaupapa, if you like, a really nice, clear set of vision and values. And when the COVID thing, and they had a lot of practice with Whakaari White Island earthquakes, the Christchurch massacre. So when COVID came along and we were asked to get involved, that was a kind of another all hands on deck moment, if you like. And so the organisation, largely invisibly, I have to say to me personally, but went into its well-practiced overdrive, and quite innovative solutions. So, for instance, the travel industry was pretty much decimated by COVID, and certainly the first lockdown. By the time the first lockdown came around, and so I think it's the House of Travel. We pretty much recruited their staff. Good customer-facing skills, bright people who were suddenly out of a job, pulled them in, trained them up.
Very, very technologically literate, but by virtue of having come out of a call centre environment.
Exactly. Reorientated them to this, acute health issue. There were stand-ups every day. Every one of us has known in health that the ministry directives around COVID, the instructions were coming through several times a day in those first weeks and months. They're still coming through on a very regular basis. And so we basically wrapped our support around these new teams being set up. Myself and in fact, a fantastic mental health worker who set up the service David will talk about, Pua Waitanga, we ended up role-playing videos of difficult phone calls, the escalation pathways. Ruth will be all over this as well. But we also, of course, had escalation pathways from the COVID-19 line through to the mental health service lines, 1737 Need to Talk. Mm-hmm. And that segued into, just before COVID, I think, loomed so large in our minds, and a month before lockdown, Whakarongaro, which incidentally was only renamed a few months ago, so we're all just getting really fluent at turning that off. Beautifully renamed, I must say. But we took over the family violence lines and the Shine line. There are 3 or 4 family violence lines. One's for professionals in Auckland. Look, I won't go into dirty detail about it. But then COVID hit, and very quickly we, at the point at which we were going live with the staff recruited and brought over to Whakarongaro. And we were hearing from Italy, in fact, first of all, about the difficulties for women who were being in lockdown situations with abusers at home. And some of what we were hearing from Italy sounded really super interesting. And on the back of that, we, for a couple of months, May, June, July last year, we engaged in a huge piece of work that involved Shine and the Women's Refuge nationally to develop a web chat that women could use. So if they couldn't talk, they could dial 111, then they could press 55*, and that would put them directly through to police. They wouldn't have to say a word. Police could hear what's going on at the other end. Police could also track the phone and their location and send someone around if necessary. It was quite fantastic. That was one of the things. And the other thing was that we were hiding the web chats on other sites so that there's no record on a woman's phone of the fact that she's been in touch with our services. And we're just taking this a little bit further forward now. In fact, I think we might have even gone live in the last 24 hours of offering a national family violence portal in collaboration with Shine and the Women's Refuge, where we now have 24/7 coverage for women, men in those cases where it's applicable, and children around New Zealand who might be in family violence situations.
That's incredible. Would that be advertised soon, or the new service?
It's I think what we're doing is we've done what we often do in this situation, which is we've gone live in 3 sites, across 3 sites, and what that will allow us to do is troubleshoot and refine. And the moment that we're quite comfortable and really confident that we've got that right, then yes, it will be publicly talked about and publicised.
Thank you for that. I think I have an awful role as a moderator to not further develop. I think every sentence can be a webinar by itself. I mean, as a child psychiatrist, I must admit, we saw in COVID the same very thing you're describing. Kids were stuck in or really captured in houses where a lot of violence and drugs and alcohol were there, and we had to literally pick up kids from the streets. Okay, I won't go there. I'll stop myself. Hey, David. Sorry, David. Can I pick your brain? I think your name was mentioned in relation to the Pua Waitanga project, and I believe you mentioned that something about co-design. And you are on mute just before you start.
Sorry, there's a bit of background noise here. Yeah, look, the woman who Lindy described working with on that bit of development, Mel Grant, who is Māori, was really the leader of that work. But just to put it in context, I mean, the organisation has had a very strategic, deliberate focus on addressing equity now for a number of years, but in the last 18 months, that's really got to be a very serious central focus. And I think Pua Waitanga is a really good example of that, because it was a service that came a number of years ago out of issues around rural access to talking therapies. And it was a trial of delivering telephone-based talking therapies independently evaluated by the AUT e-health team. We'd originally intended that it was a little bit of funding, we'll try it, we'll evaluate it, and deliver it by phone because there was a cost to doing anything different. But if it worked well, we'd go to a Telehealth platform. One of the unexpected but not surprising findings of that evaluation was actually the delivery via telephone was highly valued, and many people commented that that was what made it accessible, and that even it was the anonymity of it. So while we are implementing at the moment now telephone or televid capability, out of that pilot came Pua Waitanga. But from the original pilot, what happened was it was one of the first experiences along with bowel screening where the organisation actually very deliberately designed through a co-design process with Māori and through a Te Ao Māori lens. And the data from Pua Waitanga in that regards is quite stunning, because not only does it actually deliver better access and outcomes for everyone than, for example, standard face-to-face primary mental health packages of talking therapy, but actually it differentially delivers better outcomes for Māori than any other group. So I think it's a really nice illustration of what we've been kind of hearing said for a long time in the health sector, which is if we get it right for Māori, we get it right for everyone. And so, for example, in high needs communities with referral-based talking therapies face-to-face, out of 100 referrals, we'll typically see 35 to 40 people, whereas actually in this service, access is 75% of everyone referred, but differentially is about 80% for Māori, which is quite astonishing because historically in face-to-face, Māori would have low access rates. And the other thing is that with the outcome measure, which is a wellbeing focused measure that crosses physical health, mental health, social wellbeing and general wellbeing, that actually outcomes for everyone are equivalent to face-to-face intervention, but actually outcomes for Māori are differentially the best of any group. So I think it's a really nice example, along with also some of the other initiatives such as bowel screening, which have very actively been designed with a Māori co-design focus, that if you do that, you can actually deliver really great outcomes for everyone, but also really go a long way towards addressing what have otherwise been equity issues.
Is it?
Yeah, go ahead, Lindy. Yeah.
Well, I'm going to prompt David, I think, a little bit, because one of the things that has been really interesting to me when I started, when I came into this organisation, I came from working in a face-to-face Māori organisation, regional Māori organisation. And I remember one of the kaumātua who sadly now is gone, but was a great friend and mentor to me, saying to me, Lindy, how can you be working in a service where it's not, kanahi, it's not face-to-face. It's, how's that going to work, without that people factor? But the reality is, and then I went and worked in primary care in the Waikato and was doing, clinics in way down the line. And the fact of the matter is that for people who are remote, or for people who aren't people that we would consider even to be in remote places, but for whom transport to a traditional health setting is difficult, the thing I've learned is that the uptake and the enthusiasm for being able to use, literally, it's the team in your pocket. You pull out your phone and you have access to advice, support, information. And in the case of Pua Waitanga, you have access to a counsellor who you can call back. You're going to get 5 sessions with them, and if you need more, you'll get more. So it's quite phenomenal, really. And any thoughts that I'd had about people being reluctant to use that have been completely turned on their head, in actual fact.
So I find it, yeah. Can I ask a question about that? I mean, it's been in my mind. I mean, I'm struggling with, my biggest thing with our therapist in my team, for example, would be the argument or the debate that even through video chat, where you can see all the effect and everything, as a psychiatrist, I would probably personally prefer to do video chat over telephone. But tell us as a psychiatrist or as therapist, what it's been. Yeah.
Can I just double check, David? Sorry,
Sure.
I've been answering some of the questions that people have been putting through, which has been fun. Yeah. And I don't know if you've mentioned that disclosure, anonymity increases sensitive disclosures by a really significant amount. The research says up to 8 to 10 times more likely on a first consultation that people are going to tell you things that would take them a long time for the trust to develop in a one-to-one environment. I think that's really important. And David, did you mention about our high rates of access of Māori? But did you also mention that we have the capacity in our service, if a Māori call taker is available within the team, we recognise that a Māori person is calling, our system can match up a Māori call taker, a member of staff, with that person. And did you mention that then engagement, and I think in our quit line, for example, I think engagement and outcomes, when a Māori person talks to a Māori staff member, outcomes in terms of what that particular call was about goes up significantly. And so there's this amazing, it's not just about access, but it's about strategic access and matching of our caller. We've got the potential, the system has the potential to match people. And then we know that outcomes are better there. And so there's this democratization that exists in the virtual field, and the ability to access at times, that our community are not working, or when they have a moment when they really feel they want to reach out. It might be 3 o'clock in the morning, yet at 7:30 in the morning, they won't reach out. And so there's a moment in time when people want to reach out. There's something about the telehealth virtual system that means that they take that moment. And often we see in the family violence lines and the sexual harm lines that people take that moment and they get a response that they may not have taken if they had to wait to 8:30. I just want to mention those things. I don't know if you mentioned those things, Dave, because I haven't been completely paying attention. All right.
Good point.
I'll go back to answering the questions on. It's good.
Thank you for doing it, by the way, Siali, because I find it quite challenging to listen to you and trying to read questions. So thinking, please keep on doing that.
No, that's fine.
I do remember when we started with some of the earlier mental health response stuff, it was how do you use the UK triage scale? How do you do really good, high standard, high quality mental health triage when you can't see someone? And it was fascinating to sit there in a group and to go through a mental state examination, which several parts of our traditional mental state examination comment on appearance, movement, and really having to do everything by voice. And all I can say is that maybe it's a little bit like losing one of your senses. The others are heightened.
Yeah. Exactly, Lindy. That's what I was going to say. That across all of our lines, I think people get really nuanced to just vocal tone and background noise and the kind of feel you get. But I mean, I think it's also, as Siali says, that people are far more open to disclosing, and so that sense of safety and anonymity is a really key thing to why these services can be so effective. Right down to things as basic also as openly talking about, being at risk in a way that they might not face-to-face, where it feels so much more personal and probably as a result unsafe to disclose.
Okay. Hey, Janine, can I direct you a question? I mean, obviously these guys do this wonderful job, and I'm still trying to process the numbers. By the way, I think I should thank you. I don't know if I said it, but I want to thank you. I think, for me as a psychiatrist sitting on the floor as a child psychiatrist, if I should have seen thousands of kids per day, even acute cases. I mean, for me, if 2 or 3 cases come in acute that day, really shuts down my clinic. Mm-hmm. I can't imagine how much of a buffer you are when it comes to helping people before they reach the EDs and the clinics. And so on behalf of New Zealand, really thank you. I'm impressed. Janine, we brought you here because of your breadth of knowledge of other services as well. So before we go back to these guys, you are overseeing a lot of or incorporating national database for other services and self-help and self-management through applications and other services. Tell us about the options there.
Sure, and there was a question earlier about sort of asynchronous e-therapy options, so I can talk a bit about that. So we have led the development of the New Zealand Health App Library, and what that does is provides independent reviews of health apps and digital solutions that you can recommend to your patients, families and whānau. So we've got over about 170 apps that are being reviewed or online programs with everything from sleep and pain issues through to e-mental health. But one of the biggest areas is e-mental health because it's just got such huge potential to improve access and to equivalent to seeing one-on-one psychologists. So there's good studies showing that e-therapy with the CBT-based programs can be as effective as in person. The key thing is encouraging is how well we sell that concept to our patients when we're describing it to them and sharing those programs with them and making sure that there is some follow-up because obviously the drop-off rates are quite high. But if it can even be your receptionist or a nurse or anyone, if you provide that follow-up just to encourage people to actually complete those courses, then they really do make quite significant improvements, and there's some good RCTs to back that up. So some of the programs that I do recommend quite a lot is there were 3 that were funded last year during COVID. So Just a Thought, Mentamia and Melon. In particular, Just a Thought has structured e-therapy programs with things for stress, anxiety, depression, and they've got sleep programs coming. So I've been watching the work over in Australia where this has evolved from for many, many years. So once I years ago when I was in ADHD, we looked at bringing it before Beating the Blues appeared. So it's been developed over many years and has a lot of research behind it. As we know, sleep and pain are two very common problems for a lot of our clients in whānau with mental health or physical health problems. And there's been quite a few questions there about the importance of taking a holistic approach and support for people. And these are two of the biggest issues which people are often dealing with. And we don't have lots of great simple solutions in general practice to help them, or even in secondary care. So there are some great e-therapy options that can support people in those areas. So I'll put a link to some of the pages where you'll find some great reviews on the Health Navigator website. We also have a section particularly for young people, because that's such a big area where we're getting so many people coming through the door with young people in distress. I was reading something just the other day that since about 2012, when smartphones came onto the market and became so much more commonly used, so then sort of quickly became sort of household items that most people had one, including young people, the rates of distress experienced by young people escalated dramatically over about 3 or 4 years. And we all know or have young people in our lives and have seen the huge impact that that's obviously just one of the potential factors, but really quite staggering how quickly those rates escalated over that time period. So we do need to have a range of tools in our kitty that we can share with clients. And I want to reach the point where we're confident to basically prescribe apps to those who would like to better use that as an option. Not going to suit everyone. Some people prefer in person. But it just increases the options for people so that you can balance that with what's going to work for them. I also encourage clients, whenever I'm seeing anyone who's in distress or may become distressed down the track, to put 1737 ready to talk in their phones before they leave. That's sort of part of the sort of safety netting that I do with clients, is to make sure that they know that anytime, day or night, they can ring. I do the same with the helpline number. So particularly when I'm talking with mothers or parents who might have children who are unwell, obviously we our own after hours number, I say you can ring our practice anytime, day or night. There's always someone you can talk to, 2 o'clock in the morning. And that just gives people a lot of reassurance and confidence that they don't have to feel so alone when they're dealing with either a family member who's sick or mentally distressed. And I also often sort of normalize it by saying you'll often have a friend or a family member or someone who can be distressed at times. So put this number in your phone so that you can access the help for them when they need it. And that can also be a way of making them feel happier to have that, and it's not just for them, whatever. So there's a few thoughts.
Yeah, to be honest, I think people, I don't know if people are aware of that, but if someone looks for a therapist, no matter where you are in this country, it's quite a difficult journey. Most therapists today in the public system and the private practices are overwhelmed, and waiting lists can vary from 3 to 6 months. Do you see any uptake more? I don't know, Lindy, David, Siale. I mean, Janine mentioned youngsters, so maybe we can dive into some specific age groups. Do you see any more or less uptakes in, say, the elderly versus the youngsters, or any particular...
Yeah, Riv, can I be very cheeky and
yes.
and just go back to what Janine was saying about the apps? I think you're going to come back to this anyway, but otherwise, before it just falls out of my brain.
Yeah.
But the future of having, I know that they've got this, I know they've got 1 or 2 of these programs that already exist around the world. One's for alcohol and drug in really persistently relapsing US veterans. The other is a mood app that patients carry on their phone. But the crucial thing, talking about joined up care, integration, and what we know works best when you send somebody off to do something by themselves, is to have the app linked to the GP's dashboard. And so you can see as the patient is entering their daily mood score. And so when the patient comes in to see you, if they're feeling really terrible on the day that they see you, they're just going to say they're terrible. But if you have access to the smiley or the grim face over the last 3 weeks, you can see, oh, well, actually, last week, you had 5 days where you were feeling really good, and that kind of thing. And we know from, the John Kerwin Journal that a better outcome is achieved if there's a health professional in somebody's life who is asking them about how they're going with it.
Yep.
Janine, is that your experience? Do you want to comment on that? Because you're more expert in this area than I am.
Look, the thing that probably a lot of people will be thinking is that we don't want to be overwhelmed with data that we then become responsible for. And but one of the opportunities is, and one of the areas I've been involved with is promoting the role of health coaches. So Maori and Pacific lay leaders who have got, who are wonderful communicators and connect with anyone, and who would perhaps have a bit more of that time to follow up and support people on that journey. And then they can escalate to us when they notice that someone has been increasingly distressed for a period of time, or ideally there's IT systems where those smarts are in place so it can trigger those alerts. But at the moment, I just don't have the capacity to be getting lots of data coming in for managing blood pressures or people's mood beyond what we're all always. I'm already doing results late at night, so I don't.
But I would like to comment, if I may. There's actually research published last year from the USA, and it had actually quite a grim outcome when it looks at apps, especially in the e-mental health. It showed that the adherence to the apps is actually, if you look at the not even long term, but more medium term, is actually really extremely low. So people are quite happy to pick up an app, but wouldn't necessarily stay on that. And I think, and as a psychiatrist, I would say, I think that when people look for help when they are depressed or anxious, part of what they're looking for in the experience is that contact, is that human contact that will listen to them, that will validate. There's something about the tone, which app doesn't always give. What we're doing, for example, in our practice, is we're trying really as much as we can to do a hybrid approach. So to use apps alongside a therapist or alongside a psychiatrist, and say, and then even if the very basic, and again, I work a lot with kids, so the fact that the child knows that, next week I'm going to ask him or her about, have you done the app, or show me your dashboard or whatever, then that's a motivator by itself. But we don't just leave them to their own device. Plus, I want to, just to mention, if we look, say, specifically about depression, we know that there are some serious cognitive biases when you are depressed. And so sometimes your interpretation of what comes out of the app will be slightly skewed or slightly more dysphoric than what it should be. And then a human factor is, again, as much as I love IT, I think human factor is always important. And this is why, for us, in our service, we just always combine apps.
And I think that's reflective of both for apps and for e-therapy platforms. Generally, drop-off rates are pretty precipitous. But actually, if you combine the use of the tool with that kind of personal encouragement, coaching, and so on, that you get better retention rates. I think that also partly reflects the state of play in terms of the IT platforms. And so someone earlier talked about the fact, I think it was Ciali said, that disclosure when it's anonymous is far higher than when it's face-to-face. Well, disclosure into platforms which people know are powered by artificial intelligence are a step even higher again, and people will be far more self-disclosing. So, and we will never have enough people to meet the burgeoning demand for mental health and addiction services. So personally, I think part of the future in terms of choices for people is also having AI-powered, much more personal interaction-focused programs that mirror what would happen in a human-to-human interaction, but which can leverage the power of anonymity, but which also mean that for those that both choose the human-to-human interaction, hopefully waiting lists can be less. And secondly, also any tool like that needs to have escalation pathways to a person-delivered service when things are of greater severity or there's risk entailed and so on.
Right. Siali, I want to one of the questions that was prompted earlier was where so you guys sit on a pile of knowledge and interactions with people, and then is whether or not this package of knowledge is transferred to then back to the GP or to a secondary service. I guess, Siali, with your acute crisis, you probably work more side by side with hospitals or emergency departments. Can any of you can you shed some light on where does this data go through after they've spoken to you guys?
So if you think about New Zealand as a really small jurisdiction, so we're still 4.5. I don't think we've reached 5 million people yet.
We're 5, Charlie.
We're at 5. You'd think at 5 million, we would have one patient management system, right? And so at the moment, our team covers a number of DHBs. Think about HCC, which Counties Manukau, it's my day job, right? So our system, when a person who's domiciled in Counties Manukau calls in with a crisis, we can take that phone call, we can enter our information directly into that patient management system, and the staff in the following morning can look at those notes, right? Unfortunately, not every system is compatible with ours, but we'd like, the ideal would be a platform where primary, secondary, and virtual healthcare systems, they spoke to each other in a really sensible way. And then, the information that we do have is so much more analyzable. It's so much really accessible. So for example, in 2016, when we set up the crisis lines, we were receiving, to start, a few hundred calls. By about 2018, we were receiving about 5,000 calls per quarter. And I need the listeners to understand that if you grade them A, B, C, ABC means you need to be seen within 8 hours. That this is a really significant thing. A is sirens, B is 4 hours, C is 8 hours. About 20% of all our calls are in that range. And so if you think about, and we got to the 10,000 calls per quarter, that means 2,000 of our calls are people that are highly distressed and are psychologically very distressed state. This year we've hit 14,000 per quarter. What I'm trying to figure out is, I keep thinking it's going to plateau. I keep thinking we're a population of 5 million people. There must be a kind of, I don't know how to quite say this, an average level of heightened distress that requires an acute response. I keep thinking that must plateau out at some point, and it keeps on climbing, and I can't figure out where is the plateau point. Or is it that you build a virtual service, people start responding to it, and then there's a collective consciousness that there are services out there that you can contact. That's so we build it, it's much more accessible, therefore people use it. But actually, acute distress doesn't work that way. Acute distress doesn't keep climbing just because there's a service available for it. Acute distress is very different. Acute distress requires a set of circumstances that make a human being really struggle in a moment in time. That seems to be climbing. So that's not in response to the fact that we've built the service. That has to be in response to what people are experiencing out there in the community. And so what I like to say is that there's an enormous amount of information, and if you break that information down by age, who's calling us and what age groups? If you break that down to ethnicity, what percentage of Pacific Island population or the elderly or the Māori are using acute services? There's so much information that tells us about what's going on in our community, but our systems don't communicate to each other. And if somebody wanted access to this information, the time and effort you'd have to put in to pull this information, that itself requires a team of people, requires some funding just to look at information. So those are the types of issues. Don't know how useful that comment was, but just thought it would help kind of FYI.
It's very useful. I can tell you the question of plateau is, it's a really nice question. I can quote from the child psychiatry around the world. We're looking into a doubling of the number of referrals, anything between 6 and 10 years in pretty much every country. So New Zealand is about 10 to 9 years. So I've been here for 9 years now, and we've seen at least one double up where the availability of therapists actually declines. In New Zealand, we're seeing a reduction in the number of available therapists because of retirement. We're not really quick enough in training more therapists or doctors for that matter. I know that GPs, we all talk about, the GPs being the kind of the pivot of we'll do whatever we do and the GP will take care from there. The GPs are way beyond overwhelmed. And here's an interesting fact. I was doing some statistical research about the crisis of mental health, and I was looking at papers and statistics from all around the world, and use all sorts of databases in Google. And then I keep on seeing the word crisis and crisis and crisis. And then all of a sudden noticed that I'm looking at papers and newspaper bits from 10, 15 years back. So the fact is that we're using the word crisis for the past 10 or 15 years by itself means something. We are constantly feeling that we're not doing enough. There's ever so, need for more and more and more services, and we're just not meeting the need.
Yariv, at this point, I've got to do a plug for the Access and Choice Integrated Primary Mental Health Addiction.
Go for it, yep.
It's great to see that there's actually a HIP or health improvement practitioner among the group that have joined the webinar. But I mean, you're right, but I think that this integrated model, which actually puts a therapist, a health improvement practitioner, a health coach, and access to NGO support into primary care is transformative in that regard, in that not only is it making services more accessible to people in their community without referral being needed and in the moment, but also within a traditional primary care brief intervention model, one FTE therapist can provide services to about 225 to 250 people a year. Whereas within this, in the moment, in the practice, one-off intervention with an open door to come back model of care, one FTE can see 700 plus people in a year. Mm. And actually we're seeing, despite the brevity of the intervention, that the original pilots showed 6-month follow-up, that people had actually sustained changes they'd made. And that very much mirrored the overseas evaluations of these kinds of models of care. So it's not the solution to everything, but certainly what it does mean is that general practice is better supported to meet the breadth of holistic need that people present with. And secondly, that actually more people can access a service for a given FTE, but still actually achieve a reasonably good outcome.
Can I add something, Yariv?
Of course, yeah.
I think one of the things, again, that I've come to recognise in myself and, within our medical community, is that when we can often talk a doomsday or sing a doomsday wire that is sometimes informed by our own personal experience of just this tsunami that's never ending, and something, I actually don't believe that. I think, when Ciali says, how many people can be distressed, I'm with you there, a lot, and we don't know what the answer to that question is. But on the flip side of that, what the model David's describing is, if you come at this as a psychiatrist from the traditional places in which we work, we would see many of these people and go, oh, yes, that's a 10 to 20 sessions of one-to-one, face-to-face psychotherapy. But actually, for the individual coming through the door with a particular problem, who doesn't have to engage in a protracted process that, can potentially be quite confusing, if you're picking the thing that's bothering them most at the time and following that through, number one, there's a generalization of the skills they learn in the ways to think about approaching any given particular problem in their lives. So despite all my years in the game, I am still a little bit hung up on the idea of helping people uncover and supporting that idea of kind of resilience and new learning.
Yeah, totally agree.
So I don't think it's a never-ending tsunami. It is, because we've always got new people coming along, but I think we can box more cleverly.
Yeah. Look, I agree, Lindy, but all of these models, the HIP health coach, the NGO support, they're based on the kind of flipping the model on its head and saying that, no, I was astonished at how people who on face value you would say had hugely complex needs still have resilience, and with the right input at the right time can actually make significant change and improve their well-being with relatively small amounts of input, which is, when I started in primary care, people were kind of saying, boo-hoo, you can't help people in 3 to 6 sessions of CBT, because everyone was kind of thinking CBT was 15 to 20 sessions. But actually the evidence showed that we could. And also when people are given the choice, the average number of sessions people stay in therapy for was at that stage 4. So I think that it's an artifact of the helping professions that we kind of think people are bottomless pits of need, whereas actually most people want a bit of help in the moment and to get on with life.
Mm.
Well, actually, on that point, I just did the Bruce Arrell's fact training and in the weekend, just took our update. And one of his figures was that in 1 week, 46% of people can improve with behavioural activation. So that's something that any one of us can do, more effective than anything we can prescribe, more effective than CBT. And so that's where all these different healthcare workers, peer support people can actually help people with that sort of behavioural activation. So something we can all take away from tonight is learning how to do that. And some of these apps can do that. One of the apps I often recommend to people is Auntie D. So I've had older Maori women who really love it. They like that concept of it sort of problem solving, any problem they're dealing with, they can put it in Auntie D and get some feedback. And just a simple intervention that can really make a difference for people.
Mm. So if we want to give our audience here like a takeaway message about resilience and I mean, there's a lot of discussion again coming from, I'm sorry, using child psychiatry again and again, but one of the theories behind why we're seeing a tsunami of demand from youngsters when it comes to mental health and more self-harm and suicide attempts is lack of resilience. In a funny way, we're saying because the world today is actually easier, we're not bred to be tougher. And I'm sorry to sound such an old school. I can quote my grandpa, who was a Holocaust survivor, and I asked him one day, I said, Grandpa, at what stage were you in the concentration camps? At what stage did you feel depressed? And he looked at me and said, didn't have time for that.
Surviving. And look, I think if you look at self-harm rates around the world and suicides, they've gone down with COVID. We know that happened in the Christchurch earthquakes. When people need to, they get on with it and they deal with stuff. The difficulty often comes afterwards in assimilating stuff. But I suppose I worry sometimes in health services that our very well-intentioned and desperate need to advocate for funding and for X, Y, and Z means that the persistent message we're putting out there is one of, the doomsday wire, if you like. So I think that just needs to be a little bit massaged and a little bit modified. And resilience, in my mind, isn't about people toughening up. It's almost the reverse, actually. And that's where, it's sort of like radical acceptance. To some degree, I mean, look, that sounds all very Zen, perhaps, and I'm not. But it's actually working with people's strengths. And I think there is a great deal in the world at the moment to be very worried about. I'm personally extremely glad that I'm old. I think it would be very difficult to be a young person in today's world. I think there's a lot to be worrying them, a lot that worries me, but, I've had a lot longer to learn a few tricks.
Yeah. One of my concerns, Lindy and Dave, is that even our telehealth response is a response that can actually enable people to be more isolated, that they can get services from us in a way that enables them to meet a need for some connectedness that you can do virtually. My concern is that we create a system that essentially feeds a growing individualism that can lead to isolation in some respects. I'm hopeful that the virtual health, if we were to think about, the future of our country and the place that virtual healthcare might have in the well-being of the nation, I'd love for it to be integrated in a way that means that people can respond and get an immediate need met. But I'm also really interested in the concept that in the process of us having contact with a New Zealander and having a conversation with somebody, I wonder if we can be facilitators of connectedness, that we are connected to our communities in such a way that we have access to a range of potential options for people that enable them to re-engage with life. Because being Polynesian, my worldview is that I do best when I'm actually when I'm engaged in healthy relationships. I don't do best when I'm doing that online, actually. And so I hope for the country that our virtual healthcare system doesn't support people to be more isolated. I hope that we, contribute to a health system that gets us all moving, gets us all, the access to the information and choice that we need to live healthy lives. Brief psychological interventions for that group in our society that can respond really well to a brief intervention, but that we can figure out that they might need more and be able to direct them to the 15 or 20 Freudian ego psychology sessions that they might need for that tiny percentage of the population that might need that. And so, I know that I don't know if we've run over time, Yariv. And while
we have about 6 minutes. Yeah, it's okay. Yeah.
Because I'm really interested to hear from the panelists, from Janine, Ruth, Lindy and Dave, about, where do they see virtual healthcare in the future, and if they have a vision for how this might, help us integrate physical and psychological healthcare in a way that's useful.
I mean, Siali, you're right. All of these, be it social media, telehealth, e-therapy, they all have, they're double-edged swords. They have enormous power for good, but potential power for harm, probably most particularly social media. But I mean, I agree. And I guess it's incumbent on us to see telehealth services as a resource which can empower people to feel better, and because I mean, we're all hardwired to connect, so to feel the confidence and ability to then kind of have a life of being surrounded by and supported by other people.
I'm just wondering whether this would be a good moment to share a story with you. Would you like a story?
A bit.
No, that's the question I was asking. Yeah.
So the interesting thing about the telehealth services is, having watched them expand, sitting on the edge of my seat, repeatedly, and very frequently feeling mildly out of my comfort zone, sometimes severely, and wondering, Siali said, how much bigger can this get before the whole thing falls over? Part of this, we put together a complex caller team, because what we found, which is the same with helplines around the world, is that at a certain point, when they've been there for a while, what you discover is that you have got a group of callers who are calling you very frequently, very commonly with exactly the same problem. And when I went back and did a deep dive and started looking at this a couple of years ago, what was remarkable is that we went live in October 2015, and all of those cases that I did that initial deep dive on had started calling in October 2015. Now, the reality was, of course, they'd previously been using the other lines before we could collect the data. And they often called multiple lines. And this group of people are people when they're face-to-face services, we have that 20-80 thing. 20% of patients create 80% of the work. That's certainly the case in mental health. Often complicated, difficult to have needs met, difficult to sometimes understand properly what those needs are. And our lines were, we realized that if we could deliver a better service to this group of people so that they weren't calling consistently, sometimes, people 60 times a day is an eye-opener. 20 times a day is not uncommon in this group, sporadically and over time. But if we could address their needs more effectively, we would free up the equivalent, I think we worked out, of 15 FTE on our mental health lines. So we set up a complex caller team. It's been really, really small, but I'd love to know whether there's anybody who's watching this who has had any contact with our complex caller team, because what we find with those people is that they, I think, what's the figure? I know 40% of the people calling 1737 are current patients of secondary mental health services.
Right.
Just think about that for a moment. Our complex caller team, that percentage will be considerably higher. These are people who often have a number of face-to-face services engaged with them. But this is their learned coping strategy, if you like. So I'm going to tell you very quickly the story of Brooke. I could choose between many cases, but she is a relatively young woman, fake name, high-functioning autism, lives alone, casual work as a security guard and in a long-term relationship. And her pattern of calling us was in flurries. So she would make 20 calls in an hour and then she'd kind of subside. Since October 2015, she has made 13,358 phone calls to our lines, several of which have resulted in police involvement at some point. She came to the complex caller team when it first started out in January 2020. And over a period of months, she was persuaded to accept 2 outbound calls from us a week to check in on her. And that was a case of just being there. That the people in the team said it was a case of just being there for her. Unfortunately, this has been a case where we did heaps of liaising, because we often do heaps and heaps of liaising. But all I can say to you is, very briefly, there have been no phone calls at all from her since the 17th of April 2021. And her goal is to become call-free. She's now having 1 outward bound call from us every 2 weeks. And we're helping her with skills to learn to manage going call-free, which is about managing her anxiety and distress, prior to her moving in with her partner. That's the happy story.
That's a great story.
Beautiful story. Hey, honestly, I would love to keep on talking to you for hours. We are actually 3 minutes to the finish line. And I was thinking to myself how I'm going to wrap up this beautiful discussion. So first of all, I want to say thank you for each one of you. It's been really, thank you for that. I think our webinars are aiming for the audience to be kind of tickled with the creativity and innovation. So you've definitely done that. I want to quote something from my background. I'm from Israel. I'm not religious, but I'm Jewish. And in Judaism, when you wake up in the morning, you make yourself say thank you for things that we take for granted. So you wake up and you say, thank you for actually being woken up and for my soul to come back from wherever you wandered during the night. The second thing we say thank you for is thank you for being able to keep my cavities hollow. So we appreciate the fact that you can actually go to the toilet, because we know as doctors that if you can't, you kind of die. And the third thing is saying thank you for putting a book in my hand so I can learn today. And I think to wrap up this day beautifully and not take it for granted that we all had this beautiful opportunity to hear you guys and learn from you, that's I will not take that for granted. So I want to say thank you to each one of you for taking the time and be here with us. I know that there have been quite a few questions that have been answered. I hope we answered everything. And obviously, like all of our webinars, it will be on the website for people to consume on demand. I think we'll say good evening at this point, unless someone else wants to say anything. Is it last minute? No? Cool. So thank you once again for David, Lindy, and Siali, and Janine, and Ruth for joining us. And good night, everybody.